we be good informed advocates for our patients, even if we're not the ones doing the prescribing. Can everybody see my slides? Cool. Okay, great. So I have no relevant financial disclosures. I'm not that fortunate. My disclaimers are what I mentioned, that one is this talk is not designed to turn you into a competent psychiatrist, but rather make you a more informed advocate for youth in foster care. And my second disclaimer is this is my favorite thing to talk about. And so as my staff knows, I could talk about it all day long. So I'll do my best to keep myself to 20, 25 minutes. So just to give you a little bit of background, and many people will know this already because there's been a good amount of kind of lay public, like media reports and that type of thing about this work as well. But the estimate is that up to 80% of children in foster care, so 4 out of 5, have one or more psychiatric diagnoses. And through some work with Dave Rubin and his group at Penn, children in foster care are prescribed psychotropic medicines at significantly higher the rates of Medicaid controls who are not in foster care. Stimulants are actually the most commonly prescribed medications, but what many people don't realize is actually the second most commonly prescribed medication are atypical antipsychotics for youth in foster care. The other thing to know, and you guys know this because you see these patients, is that comorbidity is often the rule rather than the exception. And so these are kids with very complicated mental health histories who have complicated exposures and may have one or more diagnoses. They also may have been managed by a number of different people, especially if they're moving from placement to placement. And then one of the things we know is that, and I'm a big proponent of using rating scales to help try to get some objective data from kids about their symptoms, not only when I'm doing an assessment, but also in following treatment. But a lot of these rating scales are not validated for children who've had significant complex trauma. So even some of the PTSD measures are not necessarily well designed for youth who've had significant, like multiple traumatic exposures. And so it sort of limits our ability as well, or we have to interpret these with caution. And then, as you guys know, again, I don't need to tell you that it is hard to access like high quality evidence-based psychiatric care for children with Medicaid in most states, but particularly here. So these are sort of my general approach to this work. And a lot of this is adapted from another organization for which I teach called the Reach Institute. And our mission is really around teaching primary care clinicians how to do good evidence-based mental health care, knowing that there are never going to be enough child psychiatrists out there.
As was pointed out,
and one of the most important things I've learned from this group is not so much
through my chart process can be difficult for some people to navigate an online registration.
Thank you, whoever just muted them. It's not so much like this is how you prescribe this medicine, but it's more about the principles and the general approach. And I think the single most important thing I can say is that there is no substitute for a good assessment of a child. And it has to take into context that child's environment, their development, their social stressors, their placement history. And again, one of the things that I've learned in doing this work is that, those assessments often evolve over time. And so, we try hard not to think of it as a once and done thing, but know that these kids often evolve over time. And depending on, there may be certain symptoms more present at some times than others, and, things may exacerbate and get better. And I think sometimes that feels like, am I doing, did I make a mistake? Was this the wrong assessment? But in reality, these kids really do evolve over time. And so understanding that this is a complex problem or problems, and that the clinical picture can change. And so don't box yourself into like, this is the diagnosis and this is what I'm treating, because a lot of times that changes. I think in general, when prescribing psychotropic medications, there are a number of principles that I think are really important. The first is starting low and going slow. Probably the exception to that is stimulant medications, because we can titrate those a little bit faster, as well as stopping and starting them more quickly. I tell patients this, but I will only make one medication change at a time. And I'm occasionally tempted to make more than one. And I, encourage my patients to also call me on that if that's the case. Because really, if you're changing more than one medication, it's really hard to know what your impact or your side effect or whatever else is from. Monitoring closely for side effects as well as drug interactions. I think we underestimate the possibility that for these kids who are on multiple psychotropic meds, that there may actually be adverse interactions that are happening that are actually making things worse or more complicated. And then lastly, I think especially in our clinic, we do a lot of sort of consultation and discussion as a group. And so one of the things we talk about is really being able to look at your prescribing practice and look back at your trajectory that you've taken with this patient and be able to say, you know, I followed the evidence base as much as it exists. Lastly, I think maximizing one medication before you add a second is exceedingly important. You know, again, if it's not the right medicine, that's one thing, and it may be switching rather than adding a medication, but really maximizing your first medication, especially if you're using them for the same indication, before you add a second medicine is important. And then lastly, and another point that I try very hard to stress to foster parents is mental health is a team sport. It is not a solo activity. And there is a limit to what I can do with medication. I wish that I could give kids a pill and their trauma symptoms would go away. But the truth is that does not happen. And families have to understand the limits of what we can do with psychiatric medicine. It plays a really important role for a lot of these kids who have tremendous distress and discomfort. But there's a limit to what it can do in terms of, you know, shifting a kid's behavior or emotion regulation or mood. You know, and a lot of the other interventions like therapy and you know, BMOD and parent support and things like that require a lot more investment and work on the part of the foster child and the foster parent. And so it can be a little bit more difficult to sell. So I'm gonna bring you a case that I saw a couple of weeks ago. I've changed some details in the name, obviously, but Sarah is a 16-year-old new patient who's in foster care, and she presented to our office in Charleston for a new patient visit. And she'd been in foster care for 3 years, but she'd been in many placements, and those placements were predominantly in Greenville County, and she had just moved across the state to a new foster home. And her current foster parent had had her for 6 days. And I was very fortunate when I saw this patient that I actually had a few old records, certainly not like a comprehensive summary, but I had some details from various ER notes and primary care notes and things like that. And so as I looked through these various notes, she had a number of diagnoses, including major depressive disorder, generalized anxiety disorder, DMDD or disruptive mood dysregulation disorder, ODD or oppositional defiant disorder, and then there was a mention of a bipolar diagnosis as well. And when I took a history, her symptoms that she was reporting were a lot of anxiety and hyperarousal, not sleeping well, and not concentrating well. Her mood was actually okay. She didn't have a lot of symptoms of depression. She was actually pretty honest. She reported that she'd had a suicide attempt in the past, but it had been about 3 years ago. And she denied other mental health symptoms. So she denied symptoms of depression, mania, and psychosis. And she was actually a pretty good historian of her medicine. So she was able to say, you know, I've been on these medicines for at least 6 months. I don't know why I'm on any of them. And I've only got a few days left. And her medications were as follows. So she was on Depakote extended release 250 BID, Trazodone 100 QHS, Seroquel 600 QHS, and Atarax 50 milligrams TID PRN. And of course, you know, it's 3:30 on Friday and it's a holiday weekend. And this patient, you know, is sitting in your office and she's like, I've only got 5 days of medicine left. What should I do? And the foster parent's like, you can't let her run out of medicine. So, you know, your initial thoughts might be one of the following. Why is there not a child psychiatrist to see all these patients? Why isn't this patient on my partner's schedule? I can't write all these medicines. What if I'm causing harm? Maybe I should give up this gig and open a frozen yogurt shop in a beach town nearby, which I did actually have a colleague do, or E, all of the above. And I think for a lot of us, you know, even with the very best intentions and, you know, desire to really help and support these patients, that sometimes when you see a case like this and it's Friday afternoon, because it's always Friday afternoon, that it can be really kind of disheartening to think about, you know, what can I do in terms of supporting this kid and her well-being. So I'm going to do a probably more like 60,000 foot view of medications. So talking quickly about stimulants, non-stimulant medications, medications for anxiety and depression, mood stabilizers, and atypical antipsychotic medications. So quickly to talk about stimulants, because I think this is probably the area that primary care clinicians have the most experience, is working in ADHD and titrating these medications, as well as, doing the assessment and making the diagnosis. And I think there are a couple of things that are specific to youth in foster care. The first is that the rates of ADHD are very high. So at least 10 to 20% of youth in foster care have a diagnosis of ADHD. And I think one of the things to remember about that is that ADHD is highly heritable. And so, when you have families who, especially if you have a parent who's had untreated ADHD, or maybe has comorbid substance use or something else, the likelihood of having a kid with ADHD is pretty high. One of the things we do know about stimulant medicines is they're actually highly effective when you have the right diagnosis. So there's been probably more than 200 studies of stimulants. Researchers actually started studying stimulants in the 40s, where they gave women like massive doses of Adderall, like 200 milligrams a day to lose weight. And none of them dropped dead, I'm told. But we actually have pretty good safety and efficacy data for both the methylphenidate and the amphetamine class. There are a lot of other medicines for which we don't have this kind of data. 70% of kids will respond to the first class of stimulants, and then an additional 10 to 20% of those non-responders will respond to the other class. And so my reason for mentioning that, and that's youth in general, not youth specific to foster care, that, if you're starting a stimulant or you've tried both classes and what you're doing isn't working, going back and rethinking the diagnosis or saying, is there something else going on, is probably your next step in terms of assessing a child like this. Just a brief word on the non-stimulant medications, because this question will, when I give talks about trauma and PTSD and things like this question will come up. So, the non-stimulant medications include the alpha agonists, which are, 10x clonidine, extended release 10x, and extended release clonidine, which are Intuniv and Cathay. Atomoxetine, which is Strattera. And then there's a few other, like Wellbutrin and tricyclic antidepressants and things like that we don't use very often. Atomoxetine is approved for the treatment of children with ADHD. But in head-to-head comparison with methylphenidate or Concerta, it has an effect size about half the size of Concerta. So it is clearly not as effective. And the same is true, that there's not been the same head-to-head comparison with the alpha agonists. There has been some discussion in the sort of trauma PTSD community that, stimulants in children who've had significant or complex trauma may be contraindicated. And maybe it would be better to use some of these second-line medicines. And, I think that is an interesting theory, especially when you think about the alpha agonists and how they work in terms of the, sort of hyperarousal and that type of thing. But as far as the evidence base goes, the evidence base still supports starting with stimulant medicines. But I think that's an area that there's a lot of discussion and hopefully research going on to really try to understand what may make the most sense in these kids with trauma. I also think there's probably a good population of kids who are diagnosed as ADHD and who in fact have PTSD or something else, but are sort of lumped into ADHD because that's the diagnosis they carry. So as far as the SSRIs go, and I think that, what I expected when I was first learning about this work was that, this would be the most common medicine prescribed after stimulants, but that's not the case. And some of you probably have good experience with writing SSRIs for depression and anxiety. I've just listed the 6 most common. There are a couple of newer agents that there's no pediatric data to support their use. But Prozac, Zoloft, and Lexapro all have pediatric indications. And the FDA indications don't always match the data that is out there. So there's actually, following the FDA approvals, there's been more data to support the use of these medications in youth, even if they don't necessarily carry the FDA indication for that age. And you can imagine, given these drugs are like cheap and generic, that nobody wants to go back and get that FDA indication potentially. The one thing I will say is I don't use Paxil. It's a terrible drug. It has a really short half-life. Everybody withdraws. And there's been some question about the initial efficacy data that was reported by the pharmaceutical company. So quickly on when it comes to SSRIs and PTSD. So, and this is again a question that's asked pretty often to me, because there is some data supporting the use of SSRIs for adults with PTSD, for which, an evidence-based therapy is not sufficient. And that data is not necessarily seen with children. Now, I will not say there's been an amazing amount of data or evidence, but there have been a number of trials where the group that, with PTSD that gets an SSRI versus placebo hasn't separated. And so there's not clear evidence that we should be using SSRIs for children with PTSD. Now, if they have a comorbid condition like depression or anxiety, we absolutely should use an SSRI. And I'm not saying don't ever use an SSRI for a kid with PTSD, because I think, again, it's a reasonable conjecture based on the adult data, but we just don't necessarily have the data to support that in terms of long-term. And then there's this other evidence base that exists that is like very, very limited. But there is one open label trial of guanfacine XR and Tuniv that looked at hyperarousal primarily in PTSD and did show a benefit between drug versus placebo. Again, it was open label. And then both prazosin and risperidol carry indications for PTSD associated nightmares in adults. And again, that's not to say that they wouldn't be effective in kids and that we don't ever use them, because we do. But there is not the same pediatric data in terms of supporting their use with PTSD or PTSD associated nightmares. So quickly, I want to talk about the mood stabilizers, not because I think you're going to be prescribing them lots. I hope you are not. But I do think it's helpful to understand what the evidence base is. So one of the common misconceptions is that the anti-epileptic drugs like valproic acid and carbamazepine and oxcarbazepine, that there is an indication for pediatric bipolar disorder or adolescent bipolar disorder. And that's actually not the case. There is not any good data to really support their use. That's not to say there's like zero data, but you will see, I imagine you already do, a lot of kids come into your office with a diagnosis of possible bipolar disorder. I saw one recently that was like provisional bipolar disorder, and I don't quite know what that meant. It came from an inpatient psych unit, but and they may be on one of these medications. And again, it's more about having some healthy skepticism for understanding where's the evidence base, and are we treating these kids according to that evidence base, and do we have the diagnosis right? And then for lithium, there actually is an FDA indication for bipolar disorder in children 12 and older. There's actually been some emerging data that it may be more effective than some of the other agents. But some of these other drugs, which I think sometimes as pediatricians we're a little bit more comfortable with because we're used to using them for seizures potentially. And so I do see, these kids coming on drugs like this from a well-meaning clinician who, again, may not necessarily understand the evidence base. And then again, the atypical antipsychotics do have indications, again, for acute mania, for children with bipolar disorder, as well as schizophrenia. There are a number of newer atypical antipsychotics, some of which there's pediatric data for and some of which there is not. Risperidone and aripiprazole or Abilify are probably the two that there is the strongest data, both for bipolar disorder, but also for irritability and aggression with autism. And again, we use these drugs for irritability and aggression in children without autism, but the actual indication is for with an autism spectrum disorder. And then, quetiapine or Seroquel and olanzapine or Zyprexa also have an indication for bipolar disorder. One of the things I see really commonly is people using quetiapine for sleep, which it can make patients sleepy, but it has a lot of side effects. And so again, I think just understanding what are the indications for which this drug, where do we have data for actually using this medication, I think can be helpful. I mentioned this before, but atypicals are really commonly prescribed for youth in foster care, and they're the most common psychotropic med prescribed after stimulants. As you guys probably know, there's been a lot of attention on these medications, both at the state level and nationally, in terms of really understanding how to get only the kids who need to be on these medicines on them, and also getting kids off them in a reasonable way. The other thing that I think I see far too often is that, and again, it's not that I don't wish it would work, it's that it doesn't work, is that kids are prescribed atypical antipsychotics for irritability or aggression, but they're not getting any of the other interventions like therapy or BMOD or parent training or school support or things like that. And then lastly, it's not uncommon, and I would say we probably see at least a couple every month of kids who come in on 2 atypicals in the same class. And again, it's hard to reason when it comes to the evidence base of like why that would be indicated. And I'm not saying it's never ever indicated, and I'm not saying that all I want to do is Monday morning quarterback every poor psychiatrist out there, but I think we really need to have some cautious skepticism about those kids who come to us who are on multiple atypicals. And then again, for pediatric patients, atypicals are not indicated for DMDD, which is a common misconception. So DMDD is a new diagnosis in the DSM-5 that sort of colloquially was put, how was it described to me first, was put into place so that, you know, psychiatrists would stop giving the diagnosis of bipolar when it wasn't necessarily appropriate. But DMDD falls within mood disorders. And again, it's a newish diagnosis, so we only have so much outcome data, but the best evidence really supports SSRI and stimulant use for these patients and not for atypical antipsychotics. Again, anxiety and PTSD are not typically indications for atypical antipsychotics, nor is it the medicine for kids who do things that bother people. So whether that's ADHD that's not treated or ODD or whatever else, they're not typically indicated for that. Now, if there's severe aggression, that's a little bit different. And I obviously don't have time to go through all the details of the nuances, but just understanding, you know, a kid who's on Seroquel for anxiety and who's not on an SSRI, that's a kid where you say, I wonder what's going on here. And then as a quick reminder, and I think, again, this is an area that we can be really helpful, is that the atypical antipsychotics have a lot of side effects. You know, the notion that aripiprazole or Abilify is weight neutral is really not the case. So even aripiprazole has some weight gain, and the remainder of these drugs may have a lot of weight gain. And so there are a lot of symptoms that patients don't necessarily like. The QTC prolongation is only important really with Geodon or Ziprasidone. But it's also, you have to remember that like a lot of these medicines increase the QTC. So if you have a patient on multiple drugs, you know, thinking about like, do I need to get an EKG in that child or something, just to make sure that that's something that's safe. So what can we do as primary care pediatricians? So I really think being an informed advocate is important. A lot of times there are, you know, really good intentions, but these patients bounce from provider to provider to provider or facility to facility. And there may not be a lot of good kind of longevity in terms of understanding why patients are on what and when they were started and what it's designed to help with. And so I think from our perspective, understanding dosing ranges, understanding how to monitor for side effects as well as drug interactions is really important. So for what I mean by dosing ranges is, you know, if I have a kid who has a diagnosis of bipolar disorder, who's, you know, 14, who's doing great on 125 of Depakote in the morning, they probably don't have bipolar disorder, right? Because it's such a small dose of Depakote. And again, you know, as I've mentioned, it's not necessarily a first-line medicine for pediatric bipolar disorder. So again, it's not about necessarily making that change in your clinic, but really helping to be an informed advocate so that you can help guide families. I think it's really important that we help families set expectations on what medicine can and cannot do. Knowing our resources and then really coordinating with prescribing providers whenever possible. You know, especially and many of you work in more rural counties than I do, but there are a good number of counties where the only option at mental health may be an adult psychiatrist. And those folks, you know, have a couple of months of pediatric training, but that's it. And so again, really for those kids, pooling the resources between pediatrics and psychiatry to have a good assessment and plan for that child, I think is really important because your perspective is going to be different as a pediatrician. So just to go quickly back to Sarah, and I'm mindful of time, but so Sarah's medicines were Depakote 250 BID, Trazodone 100, Seroquel 600, and Atarax 50 milligrams TID PRN. And she had all of these diagnoses potentially. And so, you know, a lot of it is also thinking about what can I do for this patient today? So I am not going to fix all the woes of the world at 3:30 on Friday. But I do think that thinking about like, what can I do to keep this patient safe today is our role as pediatricians, especially when we're often the first or the only healthcare provider that a vulnerable kid may access. And so some things that we can do, we can talk about safety and suicidality and try to figure out if that kid needs more emergent treatment. So, you know, in a kid whose placement has just changed, who's living in a different part of the state, who's starting a new school, those are all significant stressors. And so one thing we can do is try to assess safety and any suicidality and figure out if we need to get that kid in for more emergent treatment. I can't tell you how many of these kids we see who come on atypicals who have never had the high-risk monitoring labs. And I'm happy to send out the reference for this. But the recommendation is to follow, LFTs, lipids, and hemoglobin A1C. Again, it's sort of not about Monday morning quarterbacking, but I can't tell you how many kids come out of PRTF and have never had these done. And they've been on these drugs for a year or more. And so again, it's a place where we can really jump in and help in terms of making sure that we're advocating for this kid and this kid's health and well-being is as good as it can possibly be. I think, a question about this patient is, what is the indication for Depakote? Like, is there an indication for Depakote? I've kind of picked on Depakote today unintentionally, but, sort of asking that question of like, whether when you're referring this patient or what else, like trying to really understand a good assessment and what's going on with this child and whether all the medicines are indicated. And then again, really helping to set expectations. And so that may be, I will not let you run out of medicine, but you need to find someone to see in the next 30 days or whatever it is. So setting expectations around medication management, around therapy and what's recommended, and, understanding that meds can only do so much. And so in summary, I've only run like 5 minutes over. I think a thorough assessment, which often takes place over more than one visit. And that's something I have to remind myself of a lot, as well as my team, that we want to try to get a good picture in one visit. And sometimes it takes more than that. When you're thinking about medicine, I think starting low, going slow, and maximizing one medicine before adding a second, as well as prescribing within the evidence base, is incredibly important. I do think having a healthy dose of skepticism and being a good detective when it comes to diagnoses and medication trials. I mean, I can't tell you how many kids that we get where you put all the records together and they've got 10 diagnoses, and they probably don't have all 10. Like, they may have 4, but they probably don't have 10. And then lastly, really helping families to understand that this is a marathon, not a sprint, that I cannot fix trauma overnight, and nobody can. And, really understanding like what are the evidence-based therapies out there that can support medication use in patients that need them. And then as a reminder for your CME credit, I think people are getting pretty good at this now. And the code is on the next page, so I'll leave this one up. But I'm happy to take any questions.